All right, welcome everybody. I am filling in for Victoria. My name is Andrea Bass. I'm with the Michigan Center for Rural Health. Please enter your name and organization into the chat box. If you have not already, please register for the ECHO. I've placed that registration link also in the chat box already. So if you have not registered, be sure you do. Good afternoon and welcome to the Michigan Center for Rural Health Infectious Disease ECHO session. My name, as I said, is Andrea, and I have the privilege to moderate today's session. The topic of today's session is epidemiology, clinical presentation, and diagnostic workup of HCV. A couple housekeeping items. For a more collegial environment, we will use first names only. Please be conscious of confidential protected health information while on this webinar. Raise your hand if you have a desire to speak, and please be sure your microphones are on mute. Feel free to turn your cameras on if you like. Before you speak, please say your name so we know who is speaking. The presentation will be available to everyone following today. The value of ECHO in case studies is sharing a case study, so please volunteer a case. A case form can be found on the MCRH ECHO website. And for introductions, I would like to ask everyone on today's ECHO program to rename your ECHO screen name to show your first and last name. Right click on the circle picture and click rename. Go down the list and do, oh, this is for me. So we're going to do introductions. So I have, and feel free to unmute yourself for this. I have Allison in the audience. It looks like last name is Lucianville, and I may have totally not pronounced that correctly. Allison, how are you today? Did you want to give a brief hello and introduction?
Yeah, hi. Valiant effort on my last name. It's pronounced Lucanville. But yeah, my name's Allison. I work with the Michigan Department of Health and Human Services as a hepatitis C disease intervention specialist.
Awesome. Welcome, Allison. And thank you for that last name clarification. I appreciate that. Courtney, and again with the last name, Weeks. Courtney Weeks. Feel free to correct.
Okay. Courtney Wicks, but nice to meet you. Yeah, so also it's going to be an echo to what Allison said. Same team, disease intervention specialist at the State Health Department in Michigan.
Excellent. Thank you, Courtney. Danielle Garcia. Maybe I did a little better, Danielle. Feel free to unmute yourself and say hello and introduce yourself. All right, we'll come back to Danielle. Emily Ingelsma.
Good job pronouncing my last name.
Thank you.
Hi, I'm a hepatitis C disease intervention specialist with MDHHS, just like Allison and Courtney have also said. So happy to be here.
Awesome. Yeah, thanks for coming. Jacqueline Howe, are you in the audience? Go ahead and unmic yourself and introduce yourself. Jacqueline, are you online? All right, we'll move to the next. Mary Lynn.
Sorry, I'm here.
That's okay.
Could not figure out how to unmute myself. Hi, my name is Jacqueline Howe. I'm a family nurse practitioner. I work for the Oakland County Health Division in both HIV and hepatitis C.
Welcome. Thanks, Jacqueline. And the next I have Mary Lynn Arvanitis. Feel free to correct. Welcome, Mary. Mary, are you online? All right, we'll come back to Mary. Next, I have Sarah Kilbride. Sarah, are you online?
Yes, hi. My name is Sarah Kilbride, and I'm also a hepatitis C disease intervention specialist at the State Health Department.
Excellent. Thank you. Welcome. Okay, so if Mary is online, feel free to unmute yourself. And I also have a call-in phone number of 989 with the last 4 of 1281. Caller, could you identify yourself? for attendance purposes?
Hi, my name's Melissa Hepfer. I'm from Ascension Standish Skilled Nursing. I'm the infection control nurse.
Welcome, welcome. Excellent. So I am writing down names, but be sure you find that chat box and type your name into the chat box as well. That way we have two forms of attendance in case anything gets missed. Did I miss anybody on the line that I haven't called on yet that would like to unmute themselves and introduce themselves? All right, looks like we got everybody. So are there any updates, questions, or clarification arising from the last session? Our topic update last time was update for STDs for primary care providers, or the last session's case studies. Now is the time to ask those questions before we move into the rest of the announcements. All right, I'm hearing silence. If something does come up, feel free to just raise your hand. So for the session evaluation, you're going to be typing that into the chat box, and please consider one thing from this session that you think will influence your practice to input into that chat box. So think of one thing that will influence your practice from today's session and be sure to place that in the chat box. I would like to introduce our speaker, Dr. Gulick, who will be speaking on epidemiology, clinical presentation, and diagnostic workup of HCV. Again, just a reminder, if you have questions, please raise your hand or use the chat box throughout the presentation, and we can unmute you so you can ask questions. You probably can unmute yourself, I'm assuming. But if you need any assistance with muting, I can unmute you on my end. After the didactic presentation, if there are any questions or comments, we'll leave time for that. Peter has agreed to present a case today, so please go ahead, Peter, with your case presentation.
Okay, well, move the slides together.
Oh, yes, sir. One moment. There you are.
Okay, thank you. So the goal of this whole program, this ICO project, is to try to educate, but as well as to get as many individuals out there that are doing primary care involved in treatments. And a lot of the subject we'll talk about this particular year will be geared around hepatitis C, obviously, as well as, you know, other topics about PrEP, which is used for HIV prophylaxis. And it, again, is mainly for educational purposes, but also to discuss if there's cases that you'd like to discuss that you're looking at in considering treatment. Those would be good times to do it during this particular sessions here. So the sessions will involve several different areas, and what we're going to start with is obviously is going to be hepatitis C, since that's one of the major focuses for Michigan right now, is to try to get more treatment done with hepatitis C, get more primary care involved, and then to hopefully eradicate this disease at some point, since it is a curable disease, not just a treatable disease. Next slide. So for this particular talk, I have no disclosures. Next slide. And what I want to do today is kind of go over epidemiology as well as natural history of hepatitis C, and then to discuss some of the basic screening and workup, and then to also discuss the importance of trying to get this disease condition not only diagnosed, but linked to care and then on therapy as quickly as possible. So go ahead, next slide, that's good. So this kind of gives you an overall view of hepatitis C, and it's the numbers may be a little bit different depending upon what group you ask, but it is the #1 bloodborne disease in the United States. And you can see anywhere from 2.5 to 6 million cases have been identified here, or feel that it's predicted that there are here in the United States. And unfortunately, about half of those individuals are unaware they have the disease, because many times hep C is totally asymptomatic. You can get the disease. And unlike other forms of hepatitis where you get jaundice and nauseated and have symptoms, this condition is many times asymptomatic. The majority of hep C cases that were initially diagnosed were in the baby boomers. And those were the groups between 45 and 65. And that's always been the group we focused on. And the reason why that was a high prevalence group was that Hep C really wasn't diagnosed as an entity or a virus until the late 90s, the 98, 99, and then 2000. And so individuals were exposed to this virus, and many times they were classified as having non-A, non-B hepatitis, for those of you that have been practicing for many years. And then it was obviously then recognized to be a separate entity. So that was the largest group of individuals, and that's still the group that we can't forget, and we should screen everybody within that age group at least one time. The new group, though, I think is very important to recognize, is the young adolescent individuals ages 15, 16 to 25 or 30 who have been abusing opioids. This opioid epidemic has been around since the early 2000s, and it's a real serious problem. And then the government all of a sudden wanted to put regulations on opioids and stop them and regulate them to, real regulated conditions. So a lot of individuals that were addicted to opioids went to other forms of addiction, and that included heroin use and a lot of drugs that were required needles. And so there was a lot of IV drug users that came about, and that's where we saw a large increase in hepatitis C, obviously, since it's mainly transmitted through contaminated blood. The other main risk factor group is MSMs, men having sex with men, especially HIV patients, which I tend to take care of a lot of. And so what you see there is individuals that may have hepatitis C and then have high risk sex with somebody, usually genital anal is the highest risk, and may cause hepatitis C to be transmitted through that way. Even though sexual transmission is not often seen, it is seen in this particular group. So we really have another peak as far as new cases of hepatitis C, and it's in this group that I just mentioned. Because of the fact that we're seeing more of these cases occurring acute onset, we're seeing more acute cases of hepatitis C. And this is where a patient may present. And again, clinically, they may have very nonspecific symptoms, fatigue, tiredness, but you go in and do labs, and their liver enzymes are usually in the 800s, over 1,000. And so this is usually the indication that they have acute hepatitis C. So those are areas that we have to be very cognizant of as well. And again, treating all of them is very, very important, even the acute cases. Women are very much involved with hepatitis C, and especially young women that abuse drugs. And the worry here is that once you get pregnant, you can't be treated for hepatitis C during your pregnancy. We have no approved drugs. And so the individual has to carry the baby through pregnancy, through the fact that they're actively infected with Hep C. And about 5% of babies born from women that are Hep C positive will also contract the virus. And if you're HIV co-infected, 15%. And even though it's still curable, and they are doing studies right now in children, and it's been approved in kids of 12 years of age and looking at even younger, it still can cause devastation, and it can cause some long-term problems that even when it's being cured. So you want to avoid babies getting infected by treating women and clearing it, curing it prior to them being pregnant, not having to deal with it while they are pregnant. Next slide, please. And so this is it's a slide that's been around for years, obviously, and it still holds up. Mainly the screening recommendations are those individuals that have high risk for contracting hepatitis C. And besides the baby boomers, it's injection drug users, ever injected illegal drugs, even though they might have stopped doing it, even though they might be totally off drugs for 10 years or whatever, they need to have at least one test for hepatitis C. And then some of these other areas of clotting factors and organ donation. This was when Hep C was first recognized back in the 90s, and we have much better ways of screening for all those now. Patients that have hemodialysis are at high risk. And then patients coming in with elevated liver enzymes from unknown reason. They come in for a routine physical, they have their blood drawn, and lo and behold, the liver enzymes are elevated, and you do a workup for Hep B and Hep C, or Hep A and Hep B, and they're negative. Well, Hep C has to be tested for as well. And again, that's an important area to consider. And then obviously, if you were born from a mother that was infected with hepatitis C, that baby needs to be tested. And you'd be surprised how many children of mothers that had active Hep C still hadn't been tested for it. So those individuals definitely should be tested. And then all the HIV patients, because about 30% of HIV patients have co-infection with Hep C. And if they got their HIV through IV needles, 70%. And then finally, needle sticks, any type of exposure. The usual rule is that if you get a needle stick or some type of mucosal exposure and the person has hepatitis C, your risk of contracting it are about 3%. So that's an important thing to remember. Next slide. So this is kind of where we're trying to get a better run of this condition. And it just shows you the fact that, you know, looking at the total number of cases, be it 2.5 or 4 million, whatever the number could be, but total number of hepatitis C cases. The problem is that, again, testing is very, very important. And we've got to do more and more testing at whatever facility we work at, be it an emergency room, be it a urgent care, a private practice office. Doesn't have to be restricted just to GI and ID and areas like that, because the more you test, the more you'll find. So we've got to improve that figure of individuals being aware of their diagnosis. And then even as important, if not more important, linking them to care. It's not as simple as just saying, well, you have Hep C, but you're not symptomatic, your liver enzymes aren't that high. So, you know, live with it and we'll see what happens later on. But now we have treatments that cure it. The treatments are simple to give. They're quick to give, and it's a curable condition. And it's something you don't want to have in your body that just kind of proliferates over time, because it can cause serious problems, which I'll get into. The other point is, once they're linked to care, treating them as quickly and as painlessly as possible. 8 weeks, 12 weeks of treatment, and you have a 98% chance of cure. It's not like the days of old where you had interferon and the cure, and it was a year-long treatment, and the cure rate was 20 to 40% at best. So you can see that once they're treated, the cure is very much almost superimposable on those that are treated. So we've got to improve that arm of treatment, and we've got to get this cycle into a continuum. We can't, and I'll talk about how important that is in just a minute. Next slide. So to look at the long road from screening to cure, first of all, we've got to increase the screening sites. And that includes what I just mentioned earlier, STD clinics, the one I have here in Ingham County where I work. We test individuals with STDs for hepatitis B, hepatitis C, obviously HIV. So we don't limit it to just treating the syphilis or gonorrhea or chlamydia, but we test individuals for all these other conditions as well. There's been studies done in areas where emergency rooms actually have been testing individuals at high risk, and have had enormous amount of cases diagnosed. And a couple of ERs down in Detroit have been doing it, at Henry Ford and at Wayne State. And so this is an area that can capture a lot of high risk individuals. I know that the big problem has always been they test them, they find them, but then what do we do with them? You know, some of them don't have primary care. Some of them, don't know where to, the ER docs are kind of, their hands are tied. Whereas if you can get a program together where you have, somebody like, for instance, in Lansing here, where a patient will get exposed to HIV through sexual activity, needles, whatever reason, they can immediately be sent to the health department here, and we will see them. So any patient comes into the ER that's been sexually traumatized, they can immediately send them to us, and then we'll take the ball and run with it as far as testing for HIV, putting them on post-exposure prophylaxis and those things. And the same model could be done with hepatitis C as well. Same thing for urgent care centers. And then they even did programs at pharmacies where a patient would come in and come in to buy whatever they wanted to get at the pharmacy or pick up their medications, and they would be offered free testing for hepatitis C right there. And then again, If it was positive with rapid testing, then refer to their primary care or refer to a specialist. And same thing with sterile needle exchange sites. These are really incredibly important because individuals coming in to exchange their needles are automatically tested for Hep C and HIV and Hep B. And so this is an area, again, where we can capture more patients. And because of the opioid epidemic and the fact that the only way we're going to get this under control is through developing medical assisted treatment programs, MAT sites, where they get put on buprenorphine, naloxone, et cetera, why these sites are critically important for not only testing, but treating hepatitis C. And that also goes for FQHC centers as well. And finally, the OBGYN clinics, as I said before, trying to get them so that they test for not only HIV, but Hep C. And once they're positive, treating them and curing them. Next slide. So once they get tested, once they get found to be positive, that's not the end of the story. And in the old days, it was the fact that, well, once that happened, now you had to link them to care. So there was the testing and the finding that they're positive. Then the primary care, if they were tested at another site, they were referred to their primary care with the diagnosis. And so that was another visit. And in the primary care, either, did the test, verified it or whatever, but then referred it to a specialist. So then it had to go to another thing. So there's more and more problems. And each time you try to link a person, that linkage gets broken and the patient disappears from site because they get tired of going from one site to another, and they just get frustrated and just stop. So that was a very poor model. The sites we want to develop now are integrated sites. One roof supplies the whole treatment. So under one roof, primary care, a MAT site, one of those areas like that could provide care for the patient from the beginning to the end. And so this is what we're trying to develop in Michigan as well as other states. So since the majority of individuals are drug abusers, it will be a perfect time to get them into a MAT-related program, get them on their buprenorphine, methadone, but at the same time, if they're Hep C positive, treating their Hep C at the same exact time. Because remember, it's only an 8-week to 12-week treatment. It's not lifelong. It's not a year. It's only 2 months to 3 months at most. And then the other fact was that the primary care had to get educated, had to get this, and the insurances didn't improve it, and a lot of different roadblocks in the whole system that have been eliminated in Michigan, which I'll talk about a little bit more. These roadblocks are completely gone. So for like Medicaid and that, you don't have to refer them to a specialist. You don't have to have an educational, certificate saying you've been educated on Hep C. All you have to do is want to treat, and you can treat. And there's no restrictions if they're IV drug users. If you feel that you can still treat them, and they're even actively using, go for it. Same thing with alcohol. So the restrictions that we had in the past are all lifted now, and there's no longer those restrictions, at least in Michigan. Next slide, please. And so again, the big group that we have to worry about as far as linking to care and treating is the people that use IV drugs. The baby boomers had been treated, currently are still being treated, but that's not the major peak that we have. The major spike we have now in new cases are the individuals using IV drugs. Next slide. And this just shows you the picture. Again, looking at the total, denominator here of about 2.5 to 4 million individuals living with hepatitis C in the United States, about 40%, if not even a little higher, of persons who use injection drug use have hepatitis C. And you can see how this can spread because one contaminated needle can spread enormous amount of individuals. And we saw what happened in southern Indiana where there was a contaminated needle or two. And from a couple cases of HIV, we went to over 300 cases, and many of them were co-infected with hepatitis C. Those same group, that same environment that we saw in southern Indiana is up in northern Michigan. And that's why a lot of the educational programs and ECHO projects are trying to get into northern Michigan, up into Alpena and Gladwin and those particular areas, that because of the high risks of of hepatitis C and the groups that are just high risk where there could be enormous amount of cases there. And then of the new cases of hepatitis C, 80% now are among people who use drugs. Next slide. So this just shows you again what we're trying to really emphasize with the grouping, that you have to really be careful and screen as much as possible. When you look at the gray line, which is opioid injection abuse with between 18 and 29 years of age, and the red line again looks at the opioid injection ages 30 to 39. We see that the most common group, the highest risk group, are the young individuals that are opioid users. And the dotted lines, which are almost going up parallel to the solid lines, are those with acute hepatitis C. And you can see both the gray and the red lines are going up at the same level as the opioid abuse. So that means that a lot of individuals that are abusing drugs are also getting infected with hepatitis C. And you can see the percentages of increase over 400% of acute hepatitis C and over 300% acute hep C in the respective age groups. But the majority of new cases are in that young age group, ages 18 to 29. Next slide. And so what are we doing here? What the World Health Organization wants to accomplish by the year 2030 is they want to eliminate hepatitis C. And this is the same goals that the Department of Human Health Services has in the United States, and the same goal that the Michigan Department of Human Health Services in the state of Michigan wants to accomplish. So we all want to do the same goal, and that's eradicate. And the reason I'm saying eradicate is it's not like what we're trying to do with HIV, trying to prevent new cases and control the cases we have. HIV is a treatable but not curable disease. With hepatitis C, we can eradicate it, completely eliminate it, because it is curable with 2 months or 3 months of treatment. So we want to accomplish it through goals of improving blood safety and infection control, make sure there's not contaminated blood of any type or contaminated materials. We want to try to use harm reduction measures for people who inject drugs, so that even that they are still using drugs, that they get sterile needles in replacement, so that at the time they get their sterile needles, they can be tested for many infections such as hepatitis C, HIV, hepatitis B, etc. And then expand the treatments with those that are already infected. So we want to, expand the treatment of hep C with more and more primary care, doing it more DOs, MDs, physician assistants, nurse practitioners, and even pharmacists, treating more and more cases, because the more we have out in the field, the more treatments and the more cases we're going to get cured. Next slide. So this is the linkage. This is the HCV care continuum. So we go from screening to diagnosis to linkage of care, treatment, and aftercare. And again, I'm going to emphasize the fact that the old model was they were screened in different settings. Then once they were diagnosed, they were sent to the primary care. Once the primary care saw that they were hep C, they tried to get them into a specialist, an ID, a hemo, or a GI, or a liver specialist. And we're talking about months of waiting, going here, going there, missed appointments, cancel appointments, whatever reason. A lot of patients feel very, very comfortable with their primary care, and the minute they're sent to other specialists, they tend to lose interest. They're more fearful, and many times that's where you lose them, and they don't get linked to care. And then finally, from linkage of care to treatment, there's always been the barriers of the horrible treatments, the interferons, the first generation direct acting agents, telaprevir, bocephevir, many, many roadblocks in that area as well. And then the aftercare, where once you treated them and cured them, it's still, the story's not over. You have to still monitor for recurrence if they're still using drugs, or if they have end stage, or if they have cirrhotic livers, they have to be screened for hepatitis or for hepatocellular carcinoma. So this was the continuum of care. But let's look at the next slide. What we want to do, and what's being talked about throughout the country and Michigan as well, is simplified care delivery, making it all the care that we talked about with the chain under one roof. So we do the initial testing, do the initial screening in a primary care setting. Nurse practitioner, physician assistant, pharmacist, MD, DO, that does the initial testing and does the initial screening. Once that happens, then the specialist referral is gone. The primary care, that same individual can then take the bull by the horns and do the workup to see what stage they are very simplistically, and then get them on therapy. So instead of waiting months, the most that should be done is within a week or 2 weeks at most till you get back the blood work that you need, and then get them on therapy. It's not that they have to be followed every week with blood tests on and on and on. They can have one test done at the beginning and then a test done when they're finally through with therapy to make sure they're cured, which is 3 months after they finish therapy. So non-specialist providers, as I mentioned earlier, and then decentralized care in the community. One roof covers everything. If they need MAT drugs, then do it under the same roof. And at the same time they're getting their methadone, give them their HCV therapy at the same exact time. Simple management guidelines where it's not that you have to do blood tests every week, every 2 weeks, whatever, to make sure they're not anemic, they're not, neutropenic like we saw with interferon. It's no testing is needed. Sometimes in my practice, I like to do a test after 1 month because that gives that patient a lot of motivation when they see their viral load go from 10 million to undetectable. And that just gets them even more excited to finish off that therapy. And if you have 2 months of therapy, 8 weeks, which one of the drugs is, you just basically say the light's there. You see it already. You only have 1 more month and you're done. And the curable rate is 98%. Next slide, please. So this is the natural history of Hep C. This is what we want to avoid. Acute infection is many times asymptomatic, and individuals may clear the virus, probably around 15% in general. But again, in an HIV patient, it's less than 5%. Majority of them go on to develop chronic infection. Again, many times asymptomatic. Unfortunately, the majority of them come in when they start developing end-stage liver disease, and that's not the time you want to get them. But then there's extrahepatic manifestations that occur that I'll talk about in a second. So most individuals focus just on the liver, but you'll be surprised when I show you the next slide to show how much other conditions hepatitis C can cause. About 20% will go on from chronic infection to develop Hep C over 20 years. But if you're immunosuppressed, if you're on any agents for rheumatoid arthritis, if you're HIV positive, on steroids, that increased risk is about 40% that go on to cirrhosis, and it's over 10 years. So it's a shorter period with a larger percent. Once you're cirrhotic, then the clock starts ticking, and you have about a 1 to 4% chance per year to develop liver cancer, which was the #1 cause of liver cancer, was hepatitis C. And then the decompensated cirrhosis is the same issue. 5-year survival, once you get that, is about 50%. So you want to avoid this and cure it at the early stages to prevent this. Next slide. This just shows you what I'm talking about as far as extrahepatic manifestations. Hepatitis C causes the antibodies to develop to try to get rid of Hep C, and the antibodies are known as cryoglobulins. And so a lot of times it's an antibody antigen mixture. And what these cryoglobulins can do is they can cause vasculitis when they get into the blood vessels, and they can actually cause this skin disorder called porphyria cutanea tarda, which is a blister-like lesions on the hands and wrists and sometimes arms. It's very painful, but it's a classic cause of this, a very high rate, is hepatitis C. It can cause neuropathy. It can plug up your kidneys and cause membranous proliferative glomerulonephritis. If it's monoclonal, there's a higher risk of non-Hodgkin's lymphomas. And then they can cause autoimmune thyroid disease with secondary hypothyroidism. It's been responsible for cases of type 2 diabetes, probably from destroying pancreatic cells. And then as you can see there, it can cause a condition just like inflammatory rheumatoid arthritis with arthralgias, myalgias. And if you do a rheumatoid factor, it's positive. So there's a lot of inflammation that goes on with hepatitis C throughout the body. not just the liver itself. And these can all be cured if you get rid of the hepatitis C. Next slide. So how do you diagnose it? Well, you get an antibody, that's the start. A lot of labs now are doing a reflex test. So if the antibody's positive, they reflex it over to a PCR. Because like I said before, again, if the antibody is negative, then no further testing is needed. However, if it is positive, then you want to do a PCR to see if they're acutely positive. And so the hepatitis PCR is the test that indicates active disease. And remember, about 15% clear the virus spontaneously. The majority of them will have a positive viral load. And what you do at that point is they need to be worked up a little further, you know, getting the CBC, getting the CMP to check the liver enzymes, getting their hepatitis A and B titers done, because you want to vaccinate them if they're Hep A, Hep B negative, and then working them up for the type of hepatitis C or the severe disease or the disease they have in their liver. So these are conditions that, like I said, you can go from antibody to blood work within a couple days. And so within a week, you can actually have most of your information and get ready for treatment. Next slide. So how do you evaluate the liver? This is important because you want to know, are they cirrhotic or aren't they cirrhotic? Because if they're cirrhotic, they may require a little more, just a little bit more tweaking for the treatment. And I'll get into that in just a second, because next time we talk, we'll talk more about the treatments itself. But it's important to know that, but even more so, once they're cirrhotic, they need to be screened for liver cancer for the rest of their lives. Even though the incidence of it goes down once they're cured of Hep C, there's still a risk. And that's for the cirrhotics and sometimes stage 3 as well. And so how do you do that? Ultrasound and alpha fetoprotein every 6 months. So this is what you want to know. So you do, now how do you evaluate the liver? Well, it used to be biopsy, but we've gotten away from that. So there's 2 other major methods. One is transient elastography, which is a special ultrasound, not the regular one, but a special one that measures liver dexterity. And you can tell how thick the liver is or fibrotic by the liver ultrasound that they do. That's one way. The second way that many areas don't have this special ultrasound, you can do it with blood work. The blood work you'd want to order would be a FibroSure, which looks at a bunch of biomarkers. And if the number is a certain number, that they'll give you the stage, you know that they're Hep C positive with stage 4 or cirrhosis. An easy way to do it, where you don't have to send the blood work off at all, is do a FIB-4 or APRI score. These are equations that you can look up on the Google. They'll give you what you have to fill in with. So for instance, with the APRI score, you put the patient's SGOT liver enzyme at the numerator and the normal SGOT in the denominator of this equation, and then the number there will then represent the numerator of a bigger equation, and then the denominator of that is the platelet count. And if the numbers are over 1.52, then your sensitivity for cirrhosis specificity is very high. So simple testing that you can do can many times tell you, is it cirrhosis or isn't it cirrhosis? If they're cirrhotic, now you want to do another group of tests. You want to make sure that they don't have any evidence of decompensation. So if they have a history of ascites, liver, you want to send them to the GI doctor to check for varices and make sure they didn't have any hepatic encephalopathy. If they have any history of that, they have decompensated disease. My advice, refer them to a liver transplant center, because some of those individuals will be a candidate for transplant. The next score, the Child-Pugh score, will calculate based on the things that you see, the albumin, bilirubin, et cetera, whether these are only for cirrhotic patients, whether they have evidence of compensated, meaning the liver's still working real well, versus decompensated, where definitely want to send them for a transplant. So those are the areas you want to go. Now, for those of you who say, this is getting way, way over my head, I don't want to do any of this stuff, we're cirrhotic, compensated, all this other more, let me tell you, the majority of cases you're going to see now are the early stage diseases. Why is that? Because these are young people that have recently got infected over the last couple of years, and the majority of them, 80%, maybe 90%, are early stage and not cirrhotics. Where we saw a lot of these cirrhotics was baby boomers because they carried their disease for 20, 10, 20, 30 years. And so their disease advanced by the time we diagnosed it. But this is just, again, and my advice to you, this is the purpose of this ECHO program we're doing today is for providers that may have a case that may not be certain how to initiate treatment, they can bring these cases to these programs I have, and we can discuss them with everybody present. I mean, it's nothing to, or if you don't feel comfortable doing it, send it in to the, to the program moderator here, and then she can give me the case and we can discuss them anonymously. So next thing, so you can do it as easy as possible. Next slide. So this again, simplify, simplify, simplify. The two major organizations, the Liver Organization and the Infectious Disease Society, developed guidelines for treating naive patients without cirrhosis. So you exclude cirrhosis, you screen them for drug-drug interactions. That means drug interactions. And so that means that, you don't want to do any more, you want to make sure that there's no interaction between the Hep C drug and the drugs that they're on. And so with that being said, once you do that and you exclude hepatitis B, because that's another condition, if they have active hepatitis B, then that's another virus that you're going to have to consider treating as well. But again, the percentage of that is very, very low, maybe less than 10%. So those are areas. And then afterwards, you get your test and you're either going to use the 8-week treatment, which is the Mafrit, or the 12-week treatment, which is the Epclusa. And then you can monitor them if you like I do, just to give them that positive reinforcement, or you can wait until they're done with treatment. And once they're done with treatment, you wait 12 weeks after that, and then do the final test. And if they're negative, they're cured. Next slide. So this is the main program through, the Michigan Department of Health and Human Services. And this is what they put into effect as far as April 1st of 2021. It was basically making treatment available to all Michigan Medicaid and Healthy Michigan Plan beneficiaries, removing prior authorizations for Mavericks. So that's the drug that they're, advising to use, and it's the 8-week course. There's certain areas where Epclusa may have to be used because of certain conditions I'll talk about the next time. But again, the drug is approved, no prior auths, and then you don't have to get a prescription or a consultation with a specialist. You don't have to make sure they're off their substance abuse for 6 months. You don't have to make sure they're off alcohol for 6 months. You don't have to go through all these different things. It's your discretion. If you feel they're ready to go, you do it. And there's good data. I can show you many data where a person can be actively using drugs and still get cured from hepatitis C with a 92% cure rate, which is just as astronomical. So, and then the different partnerships that were done with Wayne State, with Henry Ford, and with the group I represent right here with the Michigan Department of Community Health Services for Rural Centers. So this particular group is another group that can that is being worked with to promote as much hepatitis C awareness and treatment as possible. So there's been a lot of changes in hepatitis C over the last year or two as far as who can treat and who can't. Basically, everybody can treat. PCPs, physician assistants, nurse practitioners can all treat without having to go through this exhaustive referral and all this other stuff. Next slide. So I've got a little time. I'm going to go over to case studies, but before I do that, any questions? And I saw a couple come up on the chat. Is there anything that you can read to me or something that I can answer a question on?
Actually,
Andrea?
There was just some commentary about takeaways, but I haven't seen any questions yet.
Okay, so if there's any questions, just turn them in and then we can go over them. But what I wanted to do with these cases is I want to tie together what I just talked about into a case to show you what can be done with these cases. So I got two really interesting cases. One, as you see here, this is a 56-year-old white man diagnosed with hepatitis C. and at a new patient visit with the PCP following insurance changes. So he comes in asymptomatic, has routine blood work done, noted that his liver enzymes were up. So a workup for reason for that, and they found to be hepatitis C positive. So unknown as to when and how long he's had it. But again, he would be considered a baby boomer. So he's got a history of hypertension, hyperlipidemia, gastroesophageal reflux, gout, and he's moderately obese, and he's on a variety of medications. Why this is important is, remember, one of the facts that you have to do is when you're going to pick your drug of choice to treat, you're going to want to make sure there's no drug-drug interactions. And it's real easy to do. I went through yesterday to get prepared for this, to look through some of these drugs to see if there was drug interactions. You just put it up on the Google, you know, Mavorite or Clusa, and then put the drug that you're worried about, and it'll tell you severe reaction, moderate reaction, no reaction. I mean, it's that simple. You can go to Liverpool. There's different drug sites that'll give you that information. Patient's married, does not exercise. He drinks 2 to 4 beers a day, which again, doesn't exclude him from treatment. If you feel that he's going to be adherent, that's the main thing. I mean, if he's blitzing himself out where he can't remember where he is or who he is half the week, where he's going to forget taking his medicine, that might be a case where you don't want to treat him until he gets more, you know, aware and takes the drug every day. But again, this is not an exclusion to taking hepatitis C. So it's your discretion. He doesn't smoke, no illegal drug use. Okay, here's the issue. He was referred to a hepatitis C specialist after positive test results, missed initial appointment. Here we go. Here's our breakdown of linkage to care. So the primary care makes the initial diagnosis, now refers, now he misses the appointment. Now it's another month or 2 months or 3 months, and many things can happen during that time. So we want to avoid this. We want to avoid this situation by having the linkage stay right with the primary care. Let the primary care take the ball, let the primary care run with it. Next slide. Next, yeah. So he returns to the primary care for routine appointment. Now he gets some lab work done. So his hemoglobin is normal. His platelet count is normal as well. Normal is about 150 and above. Kidney function looks great. He's got a little bit of an elevated blood sugar. It should be less than 100. His albumin is normal and his INR is normal. What does that tell you? That tells you that the liver is working. So you don't have to worry about somebody that has a dysfunctional liver, that even if he is cirrhotic, it's more likely compensated because the liver albumin is normal and the INR is normal. The total bilirubin is normal. And then his liver enzymes are mildly up. Normal, upper limits of normal for an AST is 40 rather, and an ALT is 45. So they're mildly up. He's advised to lose weight, stop drinking, and referred again to the viral hepatitis specialist, who now has so many referrals that it's a 6-month wait. So you see where this is all going. So had this been the primary care from the beginning, he could have got all the blood work on the first visit when he saw he was hep C positive. And right now, he might be ready for treatment on this visit, or at least close to it, rather than waiting for another visit with the primary or with the hepatologist. This is where we lose patients to care. Next slide. Oh, could you go back just 1 second, real quick? Nope, the other way.
Sorry about that. Hang on.
No problem.
There we go. This slide.
Let's see. Yeah, that's like, and there one question was, do I have any way of making sure patients can stay and, stay with me? And that I try to motivate them. So I try to say, hey, you have hep C, and right away they're going to say, oh Lord, I'm not going to go on treatment. That treatment is horrible. A friend of mine had it and almost died with it, was sick for a year. I feel fine. I'm not going to be, that's their that the majority of them will say that to you, and they don't even want to talk about it anymore. But when you tell them, hey, how would you like to take 1 pill once a day for 3 months, or 3 pills once a day for 2 months, and you're cured 98% of the time, and then you don't have to worry about what the liver is what's going to happen to your liver over time if you don't do anything. And so all of a sudden, the motivation gets much better for that patient, because they're looking at a different. Most patients don't even know there's been a new treatment out there. They have no clue. So trying to motivate them. I do the motivation by telling them this is a cure. A lot of them don't even think it's curable. They think it's like HIV. It's lifelong treatment with misery and, whatever. And even if it is curable, it's only curable like 1 out of 100 times because of the severe treatment. So that's how I try to motivate them. But the point I wanted to make here is that platelets, see that you can tell just by this lab work that this patient doesn't have cirrhosis, because the platelet count of 165, if the patient had cirrhosis, their platelet count would usually be below normal. And so they'd be below 150. So even looking at routine labs, you can get a good handle on how badly their liver is. So next slide. So now he's finally referred after 6 months later. So the hepatologist sees the patient and the viral load's 5.3 million. It doesn't matter what the viral load is. It could be 5 million, it could be 10 million, it could be 50 million. The drugs work the same. There's not a need to have that viral load. The only reason the viral load is important is to tell them, or to make sure it's undetectable, and that indicates cure. The genotype also is not needed, although some insurances still want to have a genotype. So, you still order it, but really doesn't. There's 6 genotypes, and before in the old days it did matter. Now it doesn't matter. These 2 drugs I talked about, Mavorine and Epclusa, are pan-genotypic. Hep A negative, Hep B negative. What do they need? A vaccine for both. So if they are ever exposed, they don't get it. The way they did now, the hepatologist used a specialized liver ultrasound, and that's the liver elastography machine. And so that's how they determined what the stage of his liver disease is. So based on that number, 10.7 kp, kilopascals, they felt that the liver was probably a stage 3. So it wasn't cirrhosis stage 4, but it was in that early, that more advanced fibrotic stage. So right now we've got all the material we need to start treatment. Now the drinking of the beer, on the weekends only, that's not a major focus. I tell patients, why don't you just stop while we're on treatment, and that way, won't interfere with anything like that. But it's not something where it interferes with treatment or it's going to exclude him from being treated. So the next thing you have to do is look at his medications, which are listed below there, and you have to see what drugs, can have interaction. So what I did was I found that the rosuvastatin had a moderate interaction with the Mavorine, and it had a moderate interaction with Epclusa. So you could do one of 2 things. You could just stop the drug for 2 weeks or 2 months, and cardiologists would get on your back, but it's not going to make a big difference, and then just eliminate that. Or you could go to a lower dose if you want to do with either one. And then the omeprazole, that's an acid reducing agent, and you have to be careful with Epclusa, and take it 4 hours, take the omeprazole, usually 4 hours before, and then have the Epclusa taken with food. So there's different maneuvers you make. So that's how you do the drug-drug interactions. Very simple to do. And you're ready to go and start treatment. Epclusa, 12 weeks, Mavorine, 8 weeks. Next slide. Next slide. So now you have a different story now. You have a young gentleman, 22-year-old. This is the more common patient you're going to see in your office. Recent injection drug user, dropped out of college, covered by his parents' commercial insurance. He's depressed. So one of the areas you have to treat to get him over everything is his mental illness, or he's going to go right back to the drug use. So, there's a lot of comorbidities here you have to consider, not just, hepatitis C. But again, he's been, he's entered a treatment, a program, a MAT program, receiving buprenorphine. And the question here is, should you screen him for Hep C? And the answer is obviously yes, because all new cases of Hep C are in the IV drug use. This guy, the test that should be done even before CDC should be a Hep C test. So he's Hep C positive. Next slide. And now he's in the MAT program. You're in charge of the MAT program. And so you do a workup on him. So you find out, he's got his platelets are 110,000. So it's below normal. So you're thinking, this guy's got, he could have, more advanced disease. So you do more treatment and more lab work, and creatinine's normal. Albumin is normal, Normal is up to, normal is starting at 3.5, so he's normal, but kind of at the low end of normal. Liver enzymes are mildly up again, 98 and 110. His INR is normal, so liver's working. His viral load is 10 million. Doesn't matter. 10 million, the other guy is 5 million. Treatments are the same, the duration's the same. He's got a different genotype, 3, because that's the most common type in IV drug users. And he's hepatitis A and B negative, needs a vaccine. You don't have the luxury of a liver scan, so you do the testing. You do 2 tests. You do an APRI score, which is 2.2, which is 91% specific, indicating cirrhosis. And you verify that with a blood test called a FibroSure you send out. So he's got stage 4 disease, cirrhosis. So what you want to do at that point, if you don't feel comfortable, then you can give him to somebody. I mean, I'll take him at any time. A lot of my colleagues will. If he looks like he might be decompensated, and you could send him off to a liver specialist somewhere. But the basic thing is, this individual needs treatment. He's young, and if he's got this stage disease already, if you let him go any further, he's going to have, end-stage liver disease and may not even be a candidate for transplant at some point because, of the drug abuse. But now he's in the MAT program, and now's the time to maybe get him on treatment at the same time and cure him. And many times what they found was once you cure a patient from Hep C, a lot of times their stage will reverse itself. So they did biopsies 2 years after they were cured, and some people went from a stage 4 to a stage 3 or 2, which is early or moderate fibrosis or so. So there's a lot of hope involved in this kind of a situation. The other thing you're going to want to do with this gentleman is he's got to be screened for the rest of his life, unfortunately, for liver cancer with an ultrasound and alpha-fetoprotein. So again, I think I've kind of run out of time here, going right down to the bottom second, and I didn't mean to do that, but again, I wanted to really educate as much as I can, and we'll continue this program this way. So any other questions? I think I saw one just pop up, but I couldn't get it quick.
That's okay. I'll read it to you. It says, we need a warm handoff for positive patients. Provide with a follow-up appointment at a clinic at time of telling patient of positive results from ER visit. We need to make it easier to get, this is feedback. This is a takeaway. Thank you for the presentation. Thank you for your time, Dr. Gulick. So no questions.
What we really need, and for those of you that's why I want to use this site, and they've been nice enough to do this, this organization to allow us to use this site for what's known as ECHO. ECHO means we discuss cases too. We don't just do didactics, but we discuss cases and find out how to treat. And if you have cases you want to present or you have, do it anonymously. Just send it, over to Andrea, and then she'll give it to me, and I'll look it up, and we'll discuss it the next time we meet. And that's the whole purpose. ECHO is not just didactic, but it's discussing cases so that everybody out there feels comfortable treating and has an idea how to treat. And in the meantime, I'll come up with cases as well. So I'm not going to keep things going because I know we're out of time, Andrea. So I'll let you close.
Oh, thank you. I just typed my email into the chat box. You can feel free to send things my way. And then just in closing, so will we summarize the case presentation at all? And we asked about questions. Feel free to type any recommendations into the chat box. Again, your takeaways are much appreciated. Thank you, Peter, again, for presenting the case. The real learning in ECHO comes from the cases that are presented. So we urge all participants to present a case. Please remember, cases do not have to be challenging. So your evaluation is typing your takeaway into the chat box, as I said. And thank you for attending today's session. A few reminders, our next session is scheduled for March 23rd from 12 to 1 p.m. The topic is workup and therapy for HCV patients, as Peter had mentioned. And Peter will be back again. And we again urge you to send in your case studies. Cases do not need to be challenging. They can be simple questions or maybe giving an overview of staff systems at your institution setting. We will be sending out the recording and resources for this session within a couple days. So give us some time, and a CME is available for all healthcare professionals and will be found in the follow-up email. So that's all I have for you guys. And again, we're right on time. Well, maybe just a minute over. I'm going to stop recording. Thank you again.